To start this last day of presentations, we're going to hear from Jane Leicester and David Derry on a service development project to establish a joint respiratory motor neuron disease clinic.
Hello everybody, my name's Jane Leicester. I work with the Motor Neuron Disease Care Centre in the Salford Care Organisation. I've got a post that's funded by the Motor Neuron Disease Association to work with the teams to develop the pathways and to support the best care that we can for people with MND.
I'm Dave Derry. I'm lead physiotherapist for the Northwest Ventilation Service over at Wythenshawe Hospital. I'll talk to you a little bit later about what our service is, but I'll hand you back over to Jane now.
So I want to talk to you about the project that we had to establish a joint respiratory and neurology motor neuron disease clinic. First of all, I'd just like to give a little bit of background. So Greater Manchester is a conurbation in the northwest of England. It consists of 10 boroughs, each with their own health service and health commissioning groups. There's a population overall of 2.8 million and a prevalence of MND where we have about 220 people living with MND at any one time, with about 100 new cases per year. So the Greater Manchester Care Centre for MND supports all people from the point of diagnosis and through the whole journey, providing medical and emotional support at all stages. There are three specialist neurologists and either 2 or 3 specialist nurses at any one time. And we also have specialist allied health professionals as part of the team, so including speech therapy, dietetics, physio, OT, psychologists and social worker. And we're supported by the palliative care services. So as I've said, the respiratory service is actually provided to different trusts, which Dave will explain later. There is also, we have day-to-day management of people's care through the community teams in each of the boroughs as well. So as you can see, the care can be quite complex. So back in 2016, the respiratory pathway was that all people with MND would attend the care centre at Salford Royal Hospital, where they'd have the breathing tests. If there was any evidence of respiratory compromise, then they'd be referred on to the Northwest Ventilation Service. And once seen there, they'd either commence with NIV or continue to be monitored by them. If someone had gotten into acute type 2 respiratory failure, they'd be admitted to Salford Royal to commence non-invasive ventilation and then transferred, once stable, to the Northwest Ventilation Unit to be set up with home NIV. So it's very much felt that there was a lot of duplication, and also that the pathway for people in acute respiratory failure really wasn't as good as it should be. So in 2017, an audit of services was carried out by an APEP student, Dan Rice-Wilson. And the audit compared the compliance with NICE guidelines for MND between January the 1st to December the 31st in 2016. 52 patients were referred to the Northwest Ventilation Service, of whom only 17 were started on NIV at the initial assessment, and 28 were deemed to have acceptable respiratory function and followed up by the ventilation team. Of those, a further 6 were started on NIV at subsequent appointments within that year. Unfortunately, 3 patients died before they were seen, and 1 patient refused to follow up after the initial consultation. There was no data on the outcome for the other 3 patients. Also, a total of 18 patients received a cough assist machine, 5 of whom started on NIV at the same time and 13 that didn't. So the audit demonstrated that there really was a duplication of appointments between the 2 appointments, or between the 2 organisations.
Thanks, Jane. So I'm just going to tell you a little bit about the Northwest Ventilation Service. So we are a tertiary referral centre, who we're based at Wythenshawe Hospital in Manchester. So Wythenshawe is one of 3 university teaching hospitals in Manchester, the other 2 being Salford Royal and Manchester Royal Infirmary. We're actually part of Manchester University NHS Foundation Trust, which is a separate NHS trust to Salford Royal. We care for around about 1,500 patients across the region. So we cover the whole of the Northwest region, so not just including Greater Manchester. The only areas we don't cover are the Merseyside, so the Liverpool region, and parts of Lancashire, which have separate services for ventilation. But we provide long-term non-invasive ventilation and tracheostomy ventilation, and also cough augmentation therapy. So that's typically mechanical insufflation, exsufflation devices, lung volume recruitment devices, but also other forms of secretion clearance interventions. We have a specialist team, so specialist MDT, based on, we have consultant positions, specialist nurses and specialist allied health professionals. And from a physiotherapy perspective, the specialist physiotherapists, we're responsible for providing, for setting patients up onto non-invasive ventilation, tracheostomy ventilation, as well as cough augmentation therapy. We have an inpatient unit and also provide outpatient facilities and community outreach facilities as well too. And our community outreach team reviews patients in their own home. That's run by our specialist nurses and specialist physios, and we actually help to prevent unnecessary hospital admissions. We also aim to optimise quality of life and provide symptomatic relief of patients at home, as well as supporting patients coming towards the end of their life, so with appropriate and specialist palliative care support. And we liaise whenever required with the palliative care teams across the region. So towards the end of 2017, we actually set up a monthly joint respiratory neurology clinic over at Salford Royal, and that was specifically for patients with motor neuron disease. At that clinic, a respiratory consultant, so Dr. Saba Bakari, and myself, a specialist respiratory physiotherapist, we attended the clinic once a month to review patients who were at risk of or were showing signs of respiratory failure. And initially that was with a consultant neurologist present, but subsequently it moved to having a specialist nurse present in those clinics. So actually we had a true MDT there with across both services as well too. Based upon the findings from that clinic of each patient, they would either be allowed to continue just to come into the joint clinic at Salford Royal in the MND Care Centre, or alternatively they could be referred into the Northwest Ventilation Service, either to be set up onto an IV or cough augmentation therapy. What was really nice though from that clinic was, instead of what happened previously, if patients were found to be in acute respiratory failure, we could arrange for direct admission onto the Northwest Ventilation Unit, and that happened very quickly. So often within the space of less than 24 hours, and I think the quickest turnaround we had was within sort of 2 hours of the patient being seen by ourselves. They were actually within our unit, getting ready to be set up onto ventilation. So we actually reviewed the clinic, the impact of the clinic between December 2017 and November 2018. And within that time frame, we actually had 47 clinic appointments. We actually saw 33 patients. So some of those patients obviously attended for multiple appointments there. From those 33 patients, 22 referrals were made into the Northwest Ventilation Service. And there were an additional 16 patients referred into the Northwest Ventilation Service from the standard neurology clinics as well too. So a total of 38 referrals within that 12-month period were made to the ventilation team. What we found was that there was actually a reduction in the number of referrals into the ventilation service, down from 52 the year before down to 38. So there was actually 14 less patients referred into the service. As James mentioned previously, in 2016, of the 52 patients who were referred, there was only 17 of those patients that were set up onto an IV. So quite a large number of patients were attending the clinic, not unnecessarily really, and they could have just been seen over at Salford Royal. And in the 12 months from December 2017 of the 38 patients who were referred over to us in the ventilation service, 21 were set up. So 55% of those patients were actually set up onto an IV. And a further 3 were commenced onto cough assist, but didn't require an IV at that point. So it's really demonstrated that actually we're only referring patients into the service when they need to be referred into the service. So what's really nice is we're avoiding those unnecessary visits and duplication of appointments at multiple hospitals, which is not good for patients. What's been really nice in terms of the benefits from the clinic is that we can actually triage referrals into the North West Ventilation Service much better. So as I mentioned earlier, for those patients that require urgent admission, we can admit directly into into the North West Ventilation team at Wythenshawe, as opposed to having to admit them acutely into Salford Royal. So it's much better for patient experience, and it also reduces the length of stay that they have to have in hospital. We can actually highlight when patients need to be reviewed earlier on in our clinics, or if they need to be reviewed, if they need to have an inpatient admission at Wythenshawe Hospital for an IV or cough augmentation setup. And we can actually ensure that patients are following the correct pathway. So whether that be for cough augmentation therapy, whether it be for an IV setup, or whether it be for PEG insertions. So over at Wythenshawe, patients who are either at risk of developing respiratory failure or are in confirmed respiratory failure, and if they require a PEG, we can actually support their ventilation during the PEG insertion. So from the specialist team's perspective, we would support the ventilation with an IV, whilst the gastroenterologist physically inserts the PEG tube. What's been really nice is, as I mentioned previously, we've avoided those unnecessary appointments in the ventilation team at Wythenshawe, so it's freed up our clinic capacity, but also importantly, it's meant that patients don't have those duplicate appointments. But at the same time, it's ensured that we're compliant with the National Institute for Clinical Excellence guidelines around MND, in that patients must be reviewed, who are in respiratory failure must be reviewed jointly by both a neurologist and a respiratory team. We can actually give patients a much more informed decision as to what happens with an IV. So we can allow them to make a much more informed decision, So we can actually educate them around what an IV is, what cough augmentation therapy is as well too, what tracheostomy ventilation involves. So if the patient chooses not to proceed or they decline an IV, that decision can be made within the joint clinic, where they have support not only from us, but also from the MND care team, who actually probably know the patients better at this point. And we can actually refer patients into palliative care if required at this point as well too. From a professional perspective, what's been really nice is that we've actually been able to work jointly. We've shared knowledge across both services, and we've developed skills, across both services. But particularly importantly, we've really developed the communication. As Jane mentioned previously, I think communication channels weren't as good as they should have been a few years ago, whereas we've really worked on this, and our communication is much more seamless between the two different teams, which is not only a benefit to us as clinicians, but really importantly, it's to the benefit of patients and service users. What's also been nice is that we've actually been able to identify any social or physical issues or limitations which might impact upon the patient's ability to use ventilation or cough augmentation therapy. So, for example, whether patients need care packages instigating earlier on, or whether we need to liaise with our occupational therapy team in the North West Ventilation Service to try and arrange for appropriate adaptations or appropriate adaptation to patients, improving the patient's ability to engage in activity much more readily. We can access those interventions much more readily than we did previously.
So we carried out a survey of staff to find out what their sort of impressions and perceptions of the service were. We asked them to use words to describe it, and you can see the word map that was produced here. Generally, the responses were very positive, and in comments that included that patients now have less duplicate appointments. They also have conversations at the right time with the right people, and that care for people with acute respiratory failure is now more efficient. It was also said that it directly impacted on patient flow. Patients can now be referred directly from the clinic into an appointment bed or cough clinic at Wythenshawe within a matter of days. Patients seem to be grateful that they could be reviewed in one hospital as opposed to multiple hospital visits. And there was avoidance of unnecessary appointments at Wythenshawe for patients who may be, where NIV was not appropriate or they'd chosen not to proceed with it. So in terms of next steps, we actually continued to audit the service throughout 2019. And in that period, that 12-month period, there were 40 appointments for 38 patients. And there were 24 referrals into the ventilation service. So of those referrals, though, 11 were for people who were in acute respiratory failure who needed urgent admission. And certainly at least 6 of those patients would have been admitted to Salford rather than being referred to the ventilation service. But in all cases, it was possible to refer them into the ventilation unit, resulting in a shorter stay and a better care pathway. Also, 7 patients weren't referred, which is important because they're patients that would have previously been referred, so we were avoiding inappropriate referrals. Finally, really looking at the impact of the COVID pandemic, the clinics had to stop for most of this year. So we've actually set up a remote MDT meeting where we have the opportunity to discuss all the patients, to address some of the difficulties that the pandemic has presented. But this is something we would have liked to have done a long time ago, but we didn't have the mechanisms to do it. And because we were on 2 different sites, it was very difficult to organise. But now with the rise of virtual technologies, this has now proved much easier to do, and is something that we're really keen to continue with. So going forwards now, we want to continue with the virtual MDT and having the joint face-to-face clinics. We think that this has really made a difference to the care and the providing seamless care for people as they go into who require respiratory support. So thank you for listening, everybody. Dave and I are happy to answer any questions, and we've added our emails here if you want to write and ask us anything.
Thank you, everyone.
Sarah, you're
All
on
right,
mute.
I know, I got it. The unmute, dear Lord. Thank you very, very much. It's great to hear that that you had less referrals, but more appropriate referrals. That just seems like that's the key takeaway that I was getting from that. This is open for questions if anyone has any questions. I would like to, I was thinking about it just from a different perspective, like from our perspective. Do you routinely see, if you're a respiratory physical therapist, do you routinely see them in the clinic, in the multidisciplinary clinic, or only when you're called in?
We routinely have a monthly clinic. So as a respiratory physiotherapist, we do go in for that monthly clinic jointly with our consultant physician.
And is that part of the MND clinic?
So it runs kind of hand in hand with the MND service clinic, and Jane obviously can speak a little bit more detail about the MND service at Salford. But we had it's kind of a joint sort of clinic which was set up between the respiratory team, which is from my service at Wythenshawe, and then the MND service based at Salford.
Hello. Yeah, I think at Salford, the MND service, everybody who comes and has their appointments would always have breathing tests done. So right from the point of diagnosis, they would have a breathing test done. At the point where there's evidence that they have got some degree of respiratory failure, that was when they would be referred through to the services at Wythenshawe into the direct respiratory services. And I think what was happening prior to this joint clinic being set up is that people were being referred sooner because we needed to be more cautious. But now that we've actually got the means to work together, we can make sure that those referrals are going through at the right time now. So people are regularly reviewed, but it's mainly for the breathing tests.
And there are some questions coming up. Rod Harris wants to know, are you receiving referrals late due to people being diagnosed later?
I think at the moment, sort of during the COVID pandemic, we know that there's been some delay in sort of the numbers of patients coming through. I think generally no, though. I think under normal circumstances, for the most part, people are coming through when we would expect. We do get some surprise patients who come through, and we see them for the first time, and we discover they're actually already in respiratory failure. So we do get some patients like that, and they're the ones now that we can immediately we can get that sort of connection in with the ventilation unit and refer straight through to there, rather than referring into the hospital where the care centre is based, which then means that the patients have a more roundabout journey.
Right. So that even though it's later for them, it ends up being a shorter time.
Yeah.
Yeah. And then there's some specific question from Rachel Thompson about how did you get the go-ahead to start the clinic? You know, is it an informal arrangement or is it business case development?
I think initially when we proposed starting it, it was quite informally. So there were no kind of formal ties between the two organisations. So we kind of took it off our own back to try and initiate this. It did take a little bit of persuading, to certainly with our organisation's senior management, about the benefits of it. But once we were able to pull some of the audit data through and actually demonstrate to them, they kind of saw what the benefits were, and actually, particularly in terms of releasing clinic slots for our patients with Insure as well too, they definitely found that was beneficial. So it is much more formalised now, but it did take a period of time for that to happen.
Yes, you showed them the deliverables. Is this something then that you think other places throughout the country will be able to implement?
I mean, I think from in the UK, some services, the ventilation services and neurology services in a lot of hospitals are actually within the same organisation. It just happens that in Manchester, unfortunately, the two organisations that provide long-term ventilation and neurology are in separate organisations, whereas most places they do tend to be a little bit more joined up, or there are services across the country that are slightly differently. I'll pass you on to Jane in terms of the other neurology services, to whether or not she knows of any difference there.
Yeah, I'd agree with Dave that I think it depends on the setup, but I think we had a particularly complicated setup in Manchester. But I think there are probably other areas that are similar within the UK, because we have the 10 boroughs, which each have their own community therapy services. Then we have the ventilation services in one organisation, the neurology services in another organisation, and it really made the situation very complex in terms of communication and coordination of care. So I think going forwards as well, now one of the other benefits that we're hoping to see it now is that the community teams, so it's those 10 separate community teams that support people with MND, will be able to sort of communicate more directly in with the ventilation services as well, because their lines of communication have always tended to be with the care centre. So, but now with this, as this development's going forwards, now the community services have also got more direct lines of communication into the ventilation services, which I think really it's the whole thing then supports the patient pathway and makes it much more coordinated, seamless care than we would say we had previously.
That's excellent. Great work for both of you. That's going to conclude this one. If there are some other questions in the chat, if you want to take a look at them later. But thank you so much. It's excellent work that you're doing. So,
Thank you.